Giving Dr. Jayasri on isolated 6-nerve palsy, clinical neuroimaging.
Good evening to clinical assessment, role of neuroimaging in diagnosis and management. One inflammation and idiopathic are the causes of 6-nerve palsy. Microvascular ischemia is the most common cause of 6-nerve palsy, which spontaneously improves time, usually within 3 to 6 months. All this with implications often cannot be excluded. Neuroimaging. This study highlights the various etiologies of 6-nerve palsy and role of neuroimaging, and also we recommend an algorithm for clinical evaluation and need of neuroimaging. Materials and methods. Based retrospective case analysis of 185 neurologically isolated 6-nerve from Jan 2016. Inclusion criteria: congenital and acquired isolated 6-nerve palsy and multiple cranial nerve palsy was excluded. For all patients, anterior segment examination including extraocular movements, systemic and neurological examination was done and diagnosed clinically and documented with Hess and diplopia charting. Neuroimaging was ordered wherever indicated if the age of the patient is less than 50 years with or without vasculopathic risk factors, age is more than 50 years without vasculopathic risk factors, presence of neurological signs, presence of fundus pathology, and in presence of trauma. Was analyzed and interpreted. Results: out of 185 patients, males were 132 and females were 53. Age-wise distribution: 50 and less than 50 years were 75 patients, more than 50 years were 110 patients. Was 51 years with male preponderance. We divide the etiologies into ischemic and non-ischemic group. Those patients present with vasculopathic risk factors like diabetes, hypertension, hyperlipidemia, and coronary artery disease are included in ischemic group. In our study, microvascular ischemia, which constitutes 73%, which is the most common cause of isolated 6-nerve palsy. So distribution of risk factors in ischemic 6-nerve palsy in our study: diabetes constitutes 34.05%, diabetes and hypertension 21.6%, hypertension alone 11.35%, hyperlipidemia 2%. 5.4%, tumors 3.2%, idiopathic 2.16%, infective and congenital 1.08%, and restrictive pathology due to the thyroid-related ophthalmopathy only one case 0.5%. So coming to the discussion, microvascular ischemic nerve palsy is a presumptive diagnosis of the presence risk factors, clinical presentation, and clinical course. It classically presents with an abrupt onset, transitory pain, absence of other neurological findings, and spontaneous resolution over several months. For microvascular ischemic nerve palsy, other risk factors including hyperlipidemia, coronary artery disease, and left ventricular hypertrophy. In patients of all ages, they found the most common frequent association to be unknown etiology percentage. In contrast, our study revealed a different picture. Diabetes alone constituted 34.05% and hyperlipidemia 3.2%. The reason for diabetes cause higher diabetes in India as compared to imaging. The practice of obtaining neuroimaging for every patient is vasculopathic risk factors. So I presented with isolated nerve palsy which shows leukemic deposits in anterior cavernous sinus. Another patient aged 43 years with coronary artery disease underwent neuroimaging which showed preponderant hemorrhage. So these are the few pictures showing the causes of 6-nerve palsy. So majority of the microvascular ischemia nerve palsy resolves spontaneously. So observation, control of systemic condition, close follow-up is necessary. Resolve neurological evaluation and neuroimaging should be done. Diagnosing and exist. Performing neuroimaging for all patients is a costly management practice. In developing country, it may not always be feasible and financially viable. The decision of whether to image or not lies largely with the examining clinician and must be taken on a case-to-case basis depending on the index of suspicion. On the basis of a study, we propose an algorithm for clinical evaluation and need of neuroimaging in isolated nerve palsy. We divide the etiology into ischemic and non-ischemic group. In ischemic group, we ask the patient to rule out the history of cancer. If the patient history of cancer is present, we directly order neuroimaging. If there is no history of cancer, we focus on the age of the patient. If age is less than 50 years with or without vasculopathic risk factors, we go for neuroimaging. More than 50 years, any one of the valuing risk factors is present, then we observe the case, control systemic condition and close follow-up till 3 months. If a resolution occurs, regular follow-up the patient. If there is no resolution, no improvement, involvement of other cranial nerves, we go for neuroimaging. These are my references. Thank you.